If you're having a problem with dizziness or a family member with dizziness or a balance problem, hopefully we can shed some light. Kudos to you for being here, because we believe that knowledge is power. By understanding what's going on, you can advocate for yourself better as you move through the healthcare system. So many of the things that we work with people on require participation. I mean, you have to understand what's going on, and you have to participate. Many times, habit changes and even lifestyle changes. So knowledge is important. I'm going to start with a couple of definitions. Am I standing in front of a screen? Dizziness. So dizziness, we think of maybe lightheadedness, foggy sensation. Some people describe it like a couple drinks, but difficulty thinking clearly. And dizziness is a very general symptom. Probably more than half the medications have dizziness as a side effect. Vertigo is a very specific symptom where you have the feeling that the room is spinning around. It's a very intense symptom, very bothersome for most people, or that they feel that the room is spinning around them. And then balance, or the ability to maintain your body mass over top of your feet in a stable way. So those are three separate things. And I am curious, how many people are here mainly because they're interested in vertigo? Okay. How many more about a dizziness symptom? Okay. And how many about balance, really have balance issues? Okay, so the balance people have it. All right. All right. And so certainly all three can go together with some conditions. Where do we start with balance? A couple of things that you're going to hear a lot today is base of support. And that is the part down here. What's attached to sitting on the ground that you are trying to keep your weight over? Yeah, it's bottom. And of course, at that age, it's really about trunk control. They're all wobbly and just trying to keep their trunk over top of that base. And then when they start to crawl, we have a very big base of support here that's similar to a table. We have 4 legs on the ground. Well, 4 limbs, we'll say. Then, when they start to walk, the special thing about the base of support, because their balance isn't good, they have a wide base of support. And so that's another thing. And we see that also when people start to lose their balance, they start to get that wide base of support. So normal standing, we have a fairly narrow base of support. When we need to do something forceful, like lift something or throw something, we need that wide base of support because that gives us greater stability. So we think wide base of support for stability. If we want to move, if we're trying to be mobile like the ballerina, we need that very narrow base of support. Her base of support is the tip of her toe. And so there are a lot of things that we will do with the narrow base of support. So let's look at this fellow here. And what are some of the additional challenges that we put ourselves in as we try to do different activities? So first off, what about his base of support? It's narrow, his feet are close together, plus it's only really the balls of his feet are sitting on the ladder rung, so he has a pretty narrow base of support. Because his body's turned off to the right, he doesn't have full body reactions. He's kind of locked out on that right side. He's reaching outside of his base of support, and on top of that, he's got weight pulling him outside of his base of support. His visual input is not normal. Usually, when you're standing, you have a visual perspective of all your surroundings, and that's part of your balance. That visual input, and he's looking at whatever it is he's working on. So he's really taking that out of his use. And then, of course, he's up on a ladder. And doesn't he? Well, it looks like he's working on a traffic light, so he might be pretty high up. But you really could be just a couple feet up. And I've had people come in with bad fractures from step stool falls. So we generally do recommend that probably over 60, 65, try to avoid the ladders. Not everybody's doing that. All right, you're all good till the fall. Weight shifting is another thing that we talk about a lot when we're talking about balance, because most of the things we want to do really require us to shift our weight in one direction or another. Any golfers here? And golf weight shift is a really big thing, right? He wants to try to swing that club as hard as he can. He's got to get his weight precisely onto to the inner side of his left foot, and then he's got to precisely move it to the other foot as he's swinging. And so, when our balance is good, there are a lot of things that we can do with it. So mobility. The other things were kind of static positions. We were standing in one position, but for mobility, we want to move in a direction. So for walking, we actually have to shift our weight all the way to one leg so that we can swing the other leg, and then essentially we're falling forward onto that leg, shifting all our weight onto that leg and falling forward. So weight shift, base of support, and here we're actually falling and catching ourselves to walk. Running is a step harder. Now we have periods of time when our feet are totally off the ground, so essentially we're jumping from one leg to the next. And it's all good till you fall. Anybody can fall, any age. I mean, sometimes we feel a stigma about it, but we don't realize that everybody falls. And if I was walking in those shoes, I would probably fall. My business partner, he's been known to walk in shoes like that from time to time. Once a year he does it.
For a good cause.
Even the greats fall. The golfers know Dustin Johnson had a fall, missed the Masters. Anybody can fall. And so today we're more interested in the fall risk that happens as we age. And so that's what we're gonna talk about next. And I'm going to hand the microphone over to Joe.
What we want to talk about next is how to prevent that fall from happening. And so some of the statistics show that people between the age of 65 and 74, 1 in 3 will fall in any given year. Ages 75 to 84, the number goes up to 40%, and over the age of 85, 50%. 50% of people over 85 will fall in any given year. So, what are the risk factors, the top 10 risk factors for falls? If we understand the risk factors, then we'll talk about what we do in the clinic to solve those, and we'll talk about what you can do at home to help decrease your personal chances of having a fall. Having a prior fall. This is actually the number one. All right. So if you've fallen in the past, it correlates with number two. Typically, people that have fallen tend to have in the back of their head that it could happen again, and so those are 1 and 2 for your risk factors of a fall. Advanced age, we just talked about the statistics. Muscle weakness. All right, as we age, our muscles, our muscle mass decreases, and it takes more effort to maintain what you have, and so that increased effort is a lot of what we use when we talk about physical therapy. We try to get you up, get you moving, get you active, help you maintain your mobility. So gait abnormalities. So as we age, sometimes because of muscular weakness, sometimes because of other degenerative type of disorders, we tend to compensate. Okay, and those compensations allow us to have mobility, but they can also put us at risk for falling. Okay, poor vision. So as we age, our vision decreases, and vision is one of the three main sensory inputs that we get to help our balance. Okay, blood pressure issues. When people have blood pressure that is too high, too low, changes with their position, it can put them at higher risk for falls. Chronic conditions, diabetes, arthritis, stroke, Parkinson's, incontinence. These are all issues that can lead to people being at higher risk. Home hazards, which we're going to talk about, and you guys have a sheet that we'll go over to kind of help you spot some of the home hazards. And then medication use. So along with some of these conditions come medications that you take to help you with the conditions that you're facing. But all of those pills have side effects, and a lot of them have to do with dizziness and imbalance. So what we talk about with medications is just regularly looking at your list and monitoring that. So what can physical therapy do to help you with those risk factors, right? So when you come for physical therapy, we provide a thorough evaluation, and we talk about those things. Okay, we're gonna analyze the way you walk. We're going to design an exercise program for you, and we're going to help you to improve your strength, which then leads to improved confidence in your mobility. And we're going to talk about home modifications that you can make. When we can't get you to a point where you feel confident doing something, we're going to try to modify in order to help you continue to do it on your own and maintain your independence. So that evaluation, it's going to talk about your history. It's going to talk about we're going to do some strength testing so we know which muscles we need to target for you. We're going to look at functional testing. And when I say functional testing, it's going to be things that you do every day. Okay? Going up and down steps, standing up from a chair. It's going to be squatting, picking things up off the floor. Those kind of movements that challenge your balance. We want to see you do those and see how you're doing each of those movements. So some of the tests we do are a timed up and go test, a 4-square test, sit to stand test, and a gait speed test. So in addition to all those, we're going to do a sensory assessment. And that sensory assessment is going to talk about vision. It's going to look at your inner ear. And it's also going to look at proprioception, which is your ability for your joints, for your feet, to tell your body where you are in space, okay? And we're going to come up with a plan of care, and we're going to talk to you about that plan, all right? And we're going to make sure that we're on the same page. So let me go through a couple of these tests, okay? They're all in your handout. So originally when we did this, we thought maybe 5 people would show up, and we would screen each of you. But since that didn't happen, what we're going to do is you have the tests, okay? This is not something that you can't do at home, okay? I'm going to go through it. You're going to say, wow, that's easy. And then when you get home, you can carefully try it and see how you do, okay? And then if you have issues, you know who to call, okay? So here we go. So you sit down in a chair, you stand up, you walk 10 feet, you turn around, and then you come back and you sit in that same chair, all right? Somebody has to time you, and those are your cutoff marks here, all right? So find your age, find your time in seconds, all right? And so that deals with a couple things. One, you have to stand up from a chair, okay? and then you have to walk, quickly walk. You have to turn all the way around, okay? And so think about all these things that are challenging your balance here. And so what they found is that if you can't meet these time criteria, it's because either you're hesitant, you're not able to go as fast because you're cautious and fearful, or maybe you have some weakness. There are other factors that tend to slow people down. Okay, so we would address those factors. All right, 4-square test. All right, I gotta explain this picture because it's a little confusing. All right. I meant to bring the 4-square test, but there's 4 boxes. All right, and you don't have to have any particular thing here. Just take 2 pieces of tape and make an X on the floor, okay? Make a cross, all right? And so box 1, 2, 3, 4, all right? You're going to start and you're going to step forward into box 2, all right? Still facing the same way. You're going to sidestep into box 3. Then you're going to step backwards into box 4 and left back into the first box. So now you're in the same box that you started in, and then you're going to do it exactly the opposite way. All right? So you're going to go clockwise and then counterclockwise. All right? Yeah. When you do that, you have to stay facing one direction. All right? All right? Because that challenges you to step in different planes. Sidestep and backwards, all right? A lot of people don't like to step backwards, okay? And that's because you can't see where you're going, right? See, it's easy. You're taking your eyes out of the equation, okay? So cutoff for this is 12 seconds, all right? At 15 seconds, there's a higher risk of falls, okay? So, all right, and sit to stands. All right, so your ability to stand up from a chair without using your hands. All right? All right? Most people don't realize it, but that if you do it 5, 10 times in a row, it's a pretty good workout. Okay? Most of us, when we go to get up from a chair, it's instinctual to use our hands. All right? And to be safe, when you're doing that's fine. If you need to use your hands to be safe to stand, but understand that that means that there's a lower extremity weakness that you're compensating for when you push up from the chair. Okay, so what we look at is how quickly can you stand up and sit down 5 times. All right. So we'd like you to be able to stand up and sit down from a chair 5 times in less than 15 seconds. All right, gait speed. So they've done a lot of studies on gait speed, and they've shown that people, gait speed is actually an indicator of mortality. People when they start to walk slower, they don't live quite as long. So what we look at is fall risk by gait speed, okay? So if you walk at a speed that's less than 1 meter per second, or 3 feet per second approximately, then you are at higher risk of falls, okay? So we would like to see you walk faster than 1 meter per second, all right? So that's, you measure out your distance, all right, 100 feet. All right, and then you walk 100 feet and you time yourself. All right, take distance and divide it by your time, and you get your feet per second. Okay. All right. So, what do we do with all this information? Well, once we figure out which muscles are weak and which areas that you struggle in, then we're going to develop an exercise program. and an exercise program is more than just walking. Okay, so walking is great exercise. Not knocking walking. I think walking is great, but your program needs to be designed in a way that challenges muscles in multi-planes or a multi-planar program. So just straight walking isn't going to help you do that. All right, it's got to be progressive. It's got to be resistance training involved with that as well. So typically the hips and the quads are the most targeted muscles in our programs. Okay, now doesn't mean that they're weak on you. Okay, we need to look at that. But what I'm showing here are two muscles, the gluteus medius and minimus in the hip, all right, that are very important to stabilize our legs and our pelvis. Okay, so has anybody ever seen anybody that walks like this? If we can't stabilize our pelvis over our legs, what happens is we have a little bit of what they call a lurch, okay, where the pelvis shifts over top of the leg, okay? That is, it's a hip weakness is what it is really what it is. And the next muscle is a picture of the quadriceps in your leg, okay? So going upstairs, standing from a chair, we have to be able to extend our knees, and that's oftentimes a combination of weakness between the hips and the thighs. So here's a highlight of where those muscles are active in the gait cycle. All right, so if you look here, when your foot hits the ground, you have activation at your glutes as well as your quadricep and the anterior tibialis, the muscle in the front of your shin. As you put more weight on your leg, the quadriceps becomes more dominant, okay, and your leg becomes more straight, okay, not totally straight, but more straight. And then as you go to toe off in the gait cycle, your calf works more, okay. So that's just a highlight of where those muscles are working as we walk. Core. Who's heard the word core before? All right, a lot of people have heard the word core. All right. Who really understands core? Right. It is everything that you see here. All right, that connects your trunk to your pelvis through to your legs. Okay. It's all the muscles, all the fascia, all that is involved through that. Now, why it's important in balance is what Mike was mentioning before in the definition of balance. Balance is our ability to maintain our center of mass, our core, over top of our base of support, which is our feet. Okay? And so when we are leaning, we are countering, all right, with muscles in order for us not to fall over. All right? And so these core muscles help us to reach. They help us to pull. They help us to do everything that we do with our extremities every day. All right? If we didn't have core muscles to stabilize us, we wouldn't be able to move in the ways that we do. We wouldn't be able to reach outside of our base of support without falling over, okay? And so when we talk about strengthening your core as a part of a thorough balance program, we talk about it because it's important, unless you don't want to do anything, okay? If all you want to do is stand still over top of your base of support, well, then you don't have to work as hard. But if you want to be able to swing a golf club or reach on a shelf and pick something up, we do have to work your core in order to help us stabilize on top of your legs. All right? And, all right, so center of gravity over base of support. That's the key. So as we age, we lose some of our mobility. Some postural issues occur, and what happens as we become a little bit stiffer and a little bit more forward flex, we change where our center of gravity actually is. Okay, and so this picture just shows you that as you change your center of gravity, you have to work harder to maintain your balance. And so motor learning can continue, all right, as we age, and it doesn't have to stop. So a lot of the things that we're going to talk about and a lot of the things that we do are to promote movement, okay? Because as we move, our body can learn from that movement. So if we're dizzy or if we're fearful of falling and we stop moving, we stop learning, all right? We stop learning how to balance. We stop learning how to move, all right? And when we stop learning how to move and balance, the situation becomes worse. And you get into a little bit of a repetitive cycle there. See how that can happen? So this picture here is just saying it doesn't have to happen, right? Not suggesting that you do any of those movements tonight. All right, by the way, not suggesting that you go home and try that. The tests, I'm okay with you trying, but avoid that. We don't want to see anybody in the emergency department. All right, so as a thank you for coming out tonight, all right, what we want to do is we've set up a beginner balance program, all right? It's not individualized to you. It's a beginner program that we start a lot of people on, all right? And so if you're interested in this program, it will have videos and descriptions and suggested dosages of exercises that you can do to start working on your balance, okay? If you're interested, I have a computer outside. I just need to get your email address, all right, and your name, and we will send it to you, okay? And that will also allow you to, it will have you sign in, you'll see the program, and you can also, if you have any questions or struggle with any of the exercises, it will offer you a way to contact us, okay? So that's our thank you to you for coming out and spending your Tuesday night with us, okay? So I do want to briefly touch base on some of the things that make us unique, okay? We work a lot with balance and fall prevention. We work a lot with dizziness and vertigo. In our Perry Hall and Lutherville locations, we have a system called the Solo Step. All right, and the Solo Step is a harness system that attaches to the ceiling, and then you wear a harness, and we are able to challenge your balance reactions. All right, so she's saying we're physical therapists at Active Life Rehabilitation. Look at the Solo Step in action. Okay, so anyway, that was it, real quick. All right, so basically, they've done studies that show when you are outside of your base of support, okay, you have to react, all right, to get yourself back upright. You have to use your core, you have to use your muscle strength, and you have to use speed, that speed of reaction to get yourself, I'm falling, I'm back upright, all right? That reaction can be trained, okay? And when we're in physical therapy, oftentimes the physical therapist has to react for the patient or we both end up on the ground, all right? And so what we do is We sense that you might not be stable, so we grab you, right? And so we're safe. But did you learn to react? Did you get the most out of that movement? Okay? No, because I reacted for you. Okay? I didn't let you go through the process of taking it to the last second. Are you gonna do it or not? Right? And so when I react for you, I stole a learning opportunity from your body. All right? But when you're in the solo step, we can let you go a little bit further because we know you're not going to fall. Does that make sense? So we can challenge you a little bit more. We can push you a little bit harder. All right? We can do things that you might be fearful of doing if you weren't in a harness. All right? And for us, and backed by the research, what that does is that improves our result. Okay? And it actually ends up giving you better function up to 6 months post intervention. They did this in a study with harnessed people on treadmills, and they were really mean. They would like cut the treadmill off, and they would stop it and move it, and so they would actually try to make you fall, and then challenge your balance in that way. So. We have the solo step in our Lutherville and Perry Hall locations, and we feel that it is beneficial to our balanced patients. So what can you do? You can exercise regularly, maximize your sensory input, check your medications, and perform a safety assessment. Modify some of your high-risk behaviors. Okay, everybody that said they were on a ladder earlier today. Also, realizing, Mike and I were just talking the other day, that we feel that a lot of falls happen when we're trying to do too much, when we're rushing, when we're moving too fast, when we're trying to do more than 3 things at a time, and what ends up happening is that we make silly mistakes. All right, and we catch our toe and we trip over something, and all of a sudden now we're on the ground. Okay, and so we hear that too often from our patients that they may have been doing something that they knew they shouldn't have been doing, and it ended up with them having a fall. All right, and know when to seek professional help. All right, so we gave you some tests today, but know that one of the top 2 risk factors of falling was a fear of falling. Right, so if you're here because you feel like you're unstable, maybe it is something that you need to get checked out. And if you pass all the tests and we don't feel like we can help you, then at least we'll give you some exercises that you can continue to do on your own. Okay. All of these things above, they can change, and you need to monitor them regularly. Right. Your medications can change. Your house can change. Your ability, your senses can, your eyesight, your senses in your feet, your exercise behaviors, all of these can change. So if you're not doing an annual assessment of some of your risk factors, well, then you're dealing with old information. So exercise regularly, be safe, be appropriate. All right, the exercises that we start you on in this program are appropriate exercises, but you need to be aware of your conditions and make sure that you're safe when you're doing them. Be consistent. All right, it's recommended that you move for 30 minutes a day. All right, do some kind of movement. 5 days a week. Be informed. Schedule an appointment if you need one, and be aware that there are local programs that talk about balance awareness and can give you more information about falling. So we do work with some of these programs, and sometimes after we've seen patients, we can refer to help them continue in the community with a community-based program. So how do you check your vision? Well, you can go to the eye doctor, right? But we can do a couple quick vision tests. And so here are some questions for you. So do I need to get my vision checked regularly? Yes. Why? Well, do you find that it's more difficult to walk in the dark? Yes, because your eyes are taken out of that experience, right? You're taking one sense away. Do you find it hard to balance with your eyes closed? Well, yes, you're taking your eyes out of the equation. Our eyes play a huge role in focusing us as we're walking through space. And Mike's going to talk a little bit about how the eyes are connected to the vestibular system in the next portion of this talk. So it's a very intricate system, but if we take our eyes out of the equation, then we're down to the vestibular system and the senses in our feet. Those are the only two senses that we have left to help us balance. And so we need our eyes, and you need to make sure that they're checked and correct. All right. So what are your feet saying? Proprioception is the ability to tell where a joint is in space. Okay. So where if I close my eyes right now, my eyes are out of the balance. Now I lift my hand. I know that my left hand is up in the air right now, because my shoulder was able to tell me that, hey, you lifted your arm, okay? I didn't have to see it to know that my hand is up in the air, okay? That's our ability. That's our joints. Our joints are sending information to our brain, all right? And so when your joints in your feet send information to your brain, it helps us to react, all right? It helps us to quickly help to stabilize or take a step and to regain our balance, because we can tell where we're losing it, and your feet start to come off the ground, and then you have to take that step. Okay, so our feet send us information. All right, some chronic conditions like neuropathy, especially in diabetes, can diminish the sensation in your feet, and it hurts our balance because we don't get that good input from the bottoms of our feet, okay? Wear proper footwear. So what do I mean by proper footwear? All right, there it is. You've all seen it. You've all seen it, all right. Right there. All right, so once a year I walk in some red stilettos for GBMC's Walk a Mile in Her Shoes event, okay? And that event supports the GBMC Safe and Domestic Violence program at the hospital, and they do very good work there. This last event, this year's event, was the second annual event, just happened last Saturday, and I still have the blisters to prove it. I did not. That's actually the picture from Saturday, and you can see I'm bare-legged there, no hose. Okay, I did the real walk. All right, I walked a mile in those shoes, and we raised $41,000 for the Safe and Domestic Violence program. So, thank you. We had over 250 walkers that participated. And if you're wondering, you don't have to wear high heel shoes to participate. Okay, so that is my son Bryson. He turned 10 months old today, and so he's going through all the steps that Mike was talking about earlier. Okay. Um,
5 years he'll deny you.
but I'll have this video to prove it. All right. So, wear a shoe that fastens. Okay? Hard and thin sole. Okay? Why a hard and thin sole? Well, a hard and thin sole helps you to be as stable and close to the ground as possible. Okay? A shoe that fastens is not a slipper, right? It has a back and it has some kind of front strap or tie, all right? Don't wear open back shoes like flip-flops or slippers. Wear only socks. Don't wear only socks. It's very slippery in your house, okay? And don't wear high heels. It's really painful. So let's talk a little bit about slippers. All right? Everybody loves slippers. They're comfortable. They're warm. They make your feet feel really good. All right? But they have no support. All right? They also are they also put you at higher risk for falls in your home. Okay? 48% of all falls happen in your home. And if you wear slippers, your chances of falling increase by 11%. All right? Here's what I'm going to suggest. I know you don't want to wear your shoes in the house because outside is dirty and inside is clean. I'm going to suggest that you get a comfortable pair of shoes that you designate as your house shoes. All right? And I'm gonna say that that you try to lose the slippers because they really do put you at increased risk. All right? So think about that from a footwear perspective. All right. Not going to talk a lot about your medications because you need to do that with your primary care or your pharmacist. All right? And they are more than happy to talk with you about that. All right? Basically, they've looked at polypharmacy, the percentage of people over the age of 75 that take more than 5 medications. 37% of men, 36% of women. All right? 5 medications. All of those medications have side effects. You need to be aware of the side effects, and you need to talk with your primary care and pharmacist about that. All right. Every one of you have a home safety assessment. It's your homework. You're going to take it home, and you're going to go through, and you're going to check off and see if there are any areas that you can improve your living space in. So it's not in the packet. It should be in your folder, but not stapled together. So it should be a loose sheet, and it should look like this. All right. People are shaking their heads. Some people have found it. It's in there, I promise. All right. Be proactive about doing some of these things. All right? I know, right? Maybe it feels like you shouldn't spend the money to do some of these things, right? But if you have a fall and then you spend the money to do it, well, then you just had a fall and you're spending the money, right? So what I would say is that try to be proactive about some of this stuff. It's really better to do it ahead of time. Again, if you need help, contact a professional and schedule an appointment. And so those are things that you can do. Make sure that you see me afterwards if you want to try to start on some of those balance exercises. And if we're going to have time for questions. Mike's going to talk now about dizziness and what what we treat from a dizziness perspective and how that can affect your balance.
So I'm going to talk about inner ear or vestibular conditions. So if you look in somebody's ear, you can only see as far as the eardrum. You have the middle ear where the bones are, and then this guy in here is the inner ear with the three, we call them the semicircular canals, and then this part here is the cochlea. That's where the sounds are created, and these nerves, the vestibular and the cochlear nerve, take signals to the brainstem. So now we have a close-up. We have a blow-up view of that inner ear because it's going to be important to know these things. This whole thing is filled with fluid. The semicircular canals and this main area called the vestibule, just like the vestibule in your house that you walk in and it leads to all the other places in the house. Well, the vestibule leads to the semicircular canals. At the front of each of these semicircular canals is a group of hair cells that look like that. And as your head is moving, whatever direction, up, down, turning, depending on the way you're turning, one of these semicircular canals is going to be stimulated as the fluid bends the hair cells. And it sends a signal directly from the nerve into the brainstem. In the vestibule are a couple other little organs that are part of the balance system, and they have these little innocent-looking calcium particles, some people call them crystals, and they sit on there, and they belong there. They perform a function, so they belong on those organs in the vestibule. Just as we have two outer ears, we have two inner ears. And it's important that the two inner ears are giving the same message to the brain. The brain is expecting both. If I turn my head to the right, the brain is expecting both ears to say the direction and the speed of my movement. There is a reflex. So this is also very important. There's a reflex that goes from the inner ear to the muscles of the eyes. And so when I turn my head to the right, that reflex drives the eyes to the left. And when I turn my head to the left, the reflex drives the eyes to the left. And we can see that here. Let's see. Oh, Joe, you want to try to do that from the mouse. Use the mouse. There it is. You can click right on the arrow. And so notice as she turns her head to the right, the eyes stay. And so that performs one very important function is as I'm walking, I can be moving my head, I can be jogging, and no matter what, my eyes can stay focused on the world around me. If you didn't have that reflex, it would be like a camera on the front of a Jeep somewhere, and it would be bouncing up and down. So that vestibular, we call it the vestibular ocular reflex, very important. And it's also very important because we can't really see what's going on in the inner ear. But we can tell what's going on in the ear by what we see with the eyes. And I compare it to maybe your when you hit the gas pedal, we don't really see what the carburetor is doing, but we can tell if the carburetor is working if the car accelerates. And so we can tell what the inner ear is doing by looking at the eyes. All right, so first condition, BPPV, benign paroxysmal positional vertigo. When you have it, you start talking to your friends, you'll find one of them have had it also. It's a fairly common condition. And in this condition, I'm losing my, oh, there it is. Okay, the particles in the vestibule that we talked about, the little calcium particles, fall off the little organs they're on and they get into the canal. Now, they don't belong in the canal. And so when you move into a certain position, lay down a certain way, the particles fall down and they overstimulate the hair cells in that inner ear. And it's not fun, what people tell me. So when you first lie down in that position, there's a short delay, and then there's an intense vertigo, a spinning that usually will last 10 to 20 seconds. They say it can last up to a minute, but I would say most people that I see, it's less than 30 seconds. We see a nystagmus as that ear that's being stimulated is driving the eyes in the other direction, and they're going over and they're bouncing back, and so they're doing this intense nystagmus thing. all the symptoms of motion sickness: nausea, vomiting, sweating, fatigue. So this one, if you can click on that, Joe, see if our YouTube, Kim did a nice job of getting this all set up. Okay, so watch your eyes. So there's the delay, and then they start going, and that feels as bad as it looks when those eyes are doing that thing. That's good. Yeah.
Yes, yeah. I know all about it.
So as wild as that is, it's very easy to treat. This is called the Epley Maneuver that you've probably heard of if you've had this condition. We turn the head towards the involved side, and it positions the canal in a certain way so that those particles can fall down. We put the head down, and unfortunately when we put the head down, the world goes, and then the particles fall to the bottom. We turn the head in the other direction, wait a little while, and then we turn the person onto their side and let the particles fall out back to the vestibule where they can be reabsorbed. And so the good news is that 70% of the time, one session will put them back in place. Another 20% of the time, people need a second session, and then there's that 10% that are our problem folks that may take a little while. Sometimes the particles can actually get stuck on the hair cells, so we need to do some things to try to loosen them off of there. About 1 in 4 will get it back again sometime within the next year. And so for the folks that get it back repeatedly, we teach them how to do the maneuvers themselves. Frequently that Epley maneuver is good. Sometimes it can be in the other canal, so we need to do some other maneuvers. Another condition that I'm going to talk about, because we see some of that, is vestibular neuritis. And this is when a virus attacks that vestibular nerve, carrying the signals from the inner ear. So again, there's the vestibular, that arrow right there, pointing to the vestibular nerve, carrying the signals to the brainstem from the inner ear. And so the virus can attack that nerve and knock 30-40% of it out. So now instead of that balanced signal coming out that we were talking about, suddenly we have maybe a 60% signal coming from one side. So you remember that the inner ears, one is pushing this way and one is pushing this way. Suddenly this one becomes weak. So this one starts pushing the eyes, and they go over and they bounce back, and for hours this goes on. So vestibular neuritis, sudden onset of vertigo due to that drop in function on one side. This is what we see, and it's called Vestibular Syndrome, severe incapacitating vertigo, loss of balance. Any movement is uncomfortable. People, when they're trying to get to the emergency department, they have to have somebody help them get there. Nausea, vomiting, sweating, all those motion sickness symptoms. So for most people, these symptoms will resolve after 2 or 3 days. But we tend to see the ones who have the lingering dizziness after that. And so that, if you've ever been seasick, it feels like that, but probably worse. I've had the seasick, but not the other part. So the first step, if a person has this kind of attack, is to the emergency department, because the differential is to decide if it's a stroke, because it looks just like a stroke in the brainstem. So you do need to get checked out. There's a test where they can move your head quickly, and they can really pick up pretty quickly whether it's a stroke or not. And then most people will get a CT scan. But it's important to be there, because if it turns out that it is a stroke, the treatment for it needs to be delivered rather quickly. I think that I've heard the window is like 4.5 hours where they like to do that TPA. So we treat the prolonged symptoms. So a lot of times these people will have, they'll have a normal inner ear function going in, and then the other inner ear is just out of whack. The brain has already corrected for it somewhat, but they still feel these dizziness, fogginess things. They feel off balance. And when they turn the head, that vestibular ocular reflex is still off, so they tend to lose their balance when they turn the head. They have problems keeping things in focus when the head is moving. When they get in busy environments, in the grocery store, or if they go to like an event like this where everybody's moving, it tends to make them feel a little worse. Good days and bad days, and then sometimes they'll be making progress and they'll have setbacks if there's fatigue or stress or some other kind of illness. Sometimes this condition can happen without the really bad immediate condition, because if the weakness comes on a little more gradually, you don't have that really bad vestibular syndrome that first couple days. So we use these video goggles, and we can look at the nystagmus eye movements, because in normal room light, you're looking at things and your brain overrides the nystagmus. And when we can put the video goggles on, we can actually see the eyes. They're doing their little thing. So this is something that we do. And sometimes the vestibular neuritis looks like the BPPV, because when they lay down, they get a little bit more of this vertigo. So we use the goggles and some other tests in the clinic to kind of differentiate between the two. So what we do with those folks is give them exercises to help recalibrate. The brain has to learn to work with the weaker side. And the other thing is, so the balancing of the medication. There's motion sickness medication that you can take, because you're still not feeling great when you have this. But the motion sickness medication actually kind of delays your ability to compensate for that weakness. And so you need the activity to make the recovery happen, but the activity makes you feel sick. So it's kind of a balance between taking the medication as much as you have to, but doing as much activity as you can as well. So some of the exercises that we do a lot of head movement exercises. We do basic functional things, changing direction, some ball tosses, and we try to get the brain involved in making these compensations, as well as different balance exercises. What we're really doing is reteaching the brain, and I always compare it to an athletic maneuver like shooting a free throw. When you first start doing it, you might not be very good at it, but as you do it over and over and again, the brain learns which muscles to fire, the timing of the muscles, the coordination, and the force. And so the brain gets automatic at it. And so as you do these exercises, as you move about and do the exercises, your brain starts to compensate for the weakness. And so the outcomes are very good. For some, it can take 6 to 8 weeks, some longer.
Is it, when this happens, and it happened to me in February and I was taken to the hospital, do you lie, I mean, when I lie down, it got worse. So you don't lie down, do you stay sit up, or what do you don't, I guess you don't want to be on your feet if you're dizzy.
Yeah, you still can lay down, but when you would lay still for a while, did it stop?
No,
did it settle down?
Growing up,
Okay.
it really got worse.
Okay. So was that for the first couple days?
That was just that one.
For the one day?
Sunday. I was exhausted. I was playing golf and doing a whole bunch of things on Saturday, and I was exhausted on Sunday, and all of a sudden this happened to me.
Yeah, for that one day, you take the medication. You take the meclizine and anything you can do to not throw up and to just settle the whole thing down and let the brain start to make corrections.
All right, but position-wise, when that happens?
I probably wouldn't be laying down.
Okay.
Yes, ma'am. Meclizine kind of, it's a suppressant a little bit, and it makes you not as sharp. And if you were working on your free throws, you want your brain sharp, right? You want it to feel all the subtleties of the muscles going. And the same thing happens if you're trying to correct for an inner ear imbalance. You want the brain to be aware of all the subtleties every time you turn your head. And so that's one of the reasons why you don't want the suppressant in your system.
Can exercise bring this iron?
Exercise can't make it happen. It can make you feel worse. And so you've got this condition, you feel a little off, and you start moving around, and it just makes you feel worse. So what some people want to do is want to sit in that dark room. And so what they really need to do, though, is to gradually get moving. So it's a balance. Do a little exercise, get a little extra rest, exercise, rest. When you're starting to feel like you've had enough, you stop. Right? You don't keep pushing through it, and then eventually you'll break through. I think it depends on how good your other vestibular nerve is, because I think the expectation is that with some loss, you should be able to function with one vestibular nerve. If the other vestibular nerve is compromised, then you have what we call a bilateral loss, and so it makes it much harder. Then you're really having to deal with using the other systems, relying on the visual system, relying on the feeling in the legs and joints, and they're just not as efficient. The vestibular system is fast. That's what's making all the fast adjustments. The other systems are slower. They're basically more primitive systems. So if you take one out completely, then you are a little more reliant on the one side. Is there anything that doesn't get worse as we get older? Yeah, that's my experience. Does hearing loss have anything to do with balance? I think hearing loss can make you less aware of noises around you and things that are going on around you. Hearing loss is not necessarily tied to vestibular loss. I guess I don't have a good answer for that, exactly how hearing affects your balance. It's not one of the systems that we typically think of as providing the sensory information for your balance. We always think of the inner ear, the vision, and the proprioception. Those are kind of the three senses that contribute to balance, not so much hearing. And especially one ear. The thing to think, though, is some conditions like Meniere's, they damage the hearing nerves as well as the nerves of the vestibular system. So you may be having decline in both of those systems on one side, not just the hearing. You may think it's only the hearing, but it could be the vestibular portion of the nerve is being damaged as well, or of the inner ear.
Mike, I put the ear picture up if you want to show.
Okay. So you can see how they're, wrong one. Okay. How they're right next to each other. This is the vestibular nerve, and this is the cochlear nerve. So, and this is your vestibular mechanism. So Meniere's is a condition that there's a swelling inside of this thing, and it can damage both the sensory part of the inner ear and the hearing part, or the cochlear part. The caption: I already diagnosed myself on the internet. I'm only here for a second opinion. So there's a lot of information out there, and I think it's a good thing to look at that information. But does it apply to you? Does it is that the exact condition? And how do you use that? So I think that's where if you have some of these conditions, it's really good to go to a professional and listen to what they have to say, somebody that you trust. If you have a specific balance problem, again, exercise programs are good, but you want some kind of assessment of really what is the factor that's causing your balance problem, because it's very complex. A lot of different things can be causing a balance problem, and you want it to address what you have going on. Being inactive is very hard on the body. If you lose the movement patterns, we're losing muscle mass by a few percentage points few percentages every year. If being sedentary is very hard on the body. And so I am also going to support what Joe said, because I ask a lot of people, I ask everybody, I said, well, so what kind of exercise do you do? Because it tells me a lot. And some people say, well, I walk, and I try to do that a few times a week. And walking is good. Walking is good exercise. And but again, you're losing muscle mass, 2 or 3% a year. You need to do strengthening exercise. That's probably the most important exercise as you get older, to do strengthening exercises. Some of the other programs that do a lot of, come on, Mike. All right, that do a lot of movement, they help you keep the different movement patterns that you need to keep fresh in your brain. So you want to do more than just walking. And some of the strengthening exercises, they're simple things like that: sit to stand out of the chair. Some things that you can do on the bottom step of your house. There are things that you can do just kind of off and on throughout the day. TV commercials. Get up, do some of the sit to stand exercises. Next show comes on, you get up and you do some bottom step exercises. So there are things for the people who don't really want to go to a senior center or someplace like that to do exercise. I don't think anybody really knows why some people don't get seasickness. And I've read a fair amount about it, so I think there's what seasickness, motion sickness is really, it's a mismatch between the signals going to the brain. So the brain is getting signals from the two inner ears, it's getting vision signals, and it's getting from the joints. So if you go below in the boat, your eyes say you're sitting in the cabin looking at the person next to you, right? And your inner ear is feeling side-to-side movement, up and down movement, and back and forward movement. And that mismatch creates the sensation of seasickness. So same thing happens in a car. You're sitting in the car and you're reading, so your eyes are saying you're sitting still reading, but your head and your inner ears are feeling the turns and the stops and the starts and the stops. So the mismatch causes the seasickness. So when you get a mismatch from the two inner ears, that's just even more drastic, because again, the two inner ears, they're the king of sensory input about motion. And when one of the inner ears suddenly drops off compared to the other, the mismatch is huge and the motion sickness is incredible. And so when you think of motion sickness, it is a mismatch of the signals. Most people can do better in the car if they sit in the front seat, so that the eyes can see what's going on, and the eyes and the inner ears and the joints are all feeling the same thing. It's when you get in that back seat and you can't really see clearly what's going on in the road ahead of you, and the inner ears are still feeling all the movement. I think that's when people tend to get more seasick. And same thing on a boat. When you go, if you stay up on deck and you keep an eye on things, you're going to do better than if you go down below and I'm getting sick thinking about it. And you're moving around and you can't see what's going on. And so that is the same spins that you get when you've had too much to drink. And really, what happens is the specific gravity of the fluid in the inner ear changes, and so the fluid starts to move in the canals, so it stimulates the canal, and that's what gives you the spins. The positional vertigo usually happens when you put your head in the position that causes the little particles to roll down in the canal. And so people do elaborate things to avoid that from happening. So the first thing they do, they realize, well, if I lay down on my right side, that's when it happens. So they'll always go down, lay on their left side. They'll try to sleep all night. They'll make their spouse switch sides, and they're going to lay on that side because they've got to lay on their left side, and they'll get up on their left side. So people do all that stuff to not make it happen. Did you do that?
No, I didn't.
Okay.
I
all right.
I listened to my nurse.
Okay.
And wound up in the hospital. No, I'm just wondering if that happens again and I drink, will that fluid moving those crystals out? I mean, maybe I should be.
No. I can't promote that. I don't think drinking affects it. Did you have the crystals, the BPPV, or did you have it sounds like you might have had the vestibular neuritis. And so drinking won't bring that back. I don't think it's.
On the meclizine and in 2 hours, 3 hours, I was back home again.
Okay.
Back in the hospital, but they didn't keep me very long.
Were you good after 2 or 3 days? Were you back to normal?
Yeah.
Okay.
It took me
Longer. See, a lot of people are, in 2 or 3 days, they're 80% of normal. They're not violently sick, but when they go and they turn their head or they're walking or make a sudden movement, they do get this little rush or they feel off balance because there's still a little bit of differential between the two inner ears. They're not completely back to where they need to be. Everybody's good? Thank you very much for coming out. We appreciate it. Okay.